screening for a disease. But the other way, which is what I'm referring to, is screening to look at all the chromosomes. And yes, donor eggs have a lower number of abnormal chromosomes, but we've been treating the traditional donor egg recipient for 20 years. And there are recipient couples that have to terminate pregnancies because of Down's embryos, okay? So what you have to remember and so I'm the embryologist and work very, very closely with physicians, and it's a team approach for all this. But physicians, I think, need to, I like to remind people that when we give fertility drugs, we're blasting eggs out of the ovaries that Mother Nature might have left hidden, okay? And so there's a lot of eggs in there. And so when you give fertility drugs, there's no signal that says just give it lipids. And so we get all kinds of it. So I'm an embryologist, so I see what happens that way. Remember, the goal isn't just to get somebody pregnant, it's to have a healthy baby. And the issue is, there are many terminations that still have to happen with in vitro. When it's going into a couple's uterus, you just don't have to think about it or hear about it. The issue is, you're going to enter into a contract with the surrogate. And depending on, in Illinois, because a lot of people want to use Illinois surrogates, there's a lot of surrogates who are great candidates, but they can't sign. They won't sign on to do a termination. And although your risk, sure, it's lower. It happens. Believe me, it happens. Okay, so that's the type of thing you need to know. So, no, you don't need it, and it's one of the things that the majority of physicians, that's what they say, we use PGD with donor egg. The main reason, it's not us that came and said, let's start using PGD with same-sex couples. It came from a demand because we were treating patients that had been elsewhere, and it was a mess with a termination or something else. So this has been over the last 10 years, this rate is 27, but same-sex couples really before that, wasn't done this way. We had to do things differently. But over the last 10 years, the demand, the request for PGD was there. And so we started, especially with international couples. And so we saw the results and the numbers, and not casting judgment, but one of the other benefits of doing PGD. So it's to screen out the embryos that are destined not to implant. All right? So, because when we don't do PGD, and I have some slides that show it instead of the words, but when we don't do PGD, we pick the embryos based on what they look like. Now, somebody said they had 4 embryos transferred downstairs, and they had their daughter, right? Somebody on the panel. That's pretty unusual, because usually they probably had a day 3 embryo transfer, and I didn't catch how old their daughter was, but maybe that was a while ago, because most groups would want to take the embryo all the way out to the blastocyst stage, which is day 5, because you're going to get the best information on which are the healthiest in terms of achieving a pregnancy. But we can't screen out, we can't see if that embryo is going to result in a miscarriage, but PGD can show us that from a chromosome standpoint. So it's the highest pregnancy rate and lowest miscarriage rate, and we've never had a pregnancy that has had to then terminate because it was Downs or something, and the PGD said it wasn't. But for those of you that came in later, because obviously, as you can tell, I'm pretty excited about PGD, only the newer version, which looks at all the chromosomes, because a lot of groups still offer what's called FISH, which just looks at 5 or 9 chromosomes, which should not even be done anymore. Okay? But it's a lot easier to do. It's like every area of medicine, it starts out decent, helps people, but once it's become replaced by the other technology, it's like, come on, you need to get on board and don't do that. Go ahead.
When How quickly do you get your results back, and then how quickly do you put the embryo in?
That's a great question. A lot of physicians also say, well, we don't want to do PGD. Now, I love physicians, so I don't want to sound like that. They know, I mean, I've been in the field forever. Excuse me, but I call them on it, you know what? Because it's the team. You need both sides as well as a really good nurse to keep everybody in check, okay? So one of the things that's said is, well, you really don't want to do PGD because you have to freeze the embryos to wait for the results. That used to be the case. And if you're current and proficient and offering it the way it should be offered, you don't even have to do that anymore. But it's a matter of how proficient you are you doing it or not? So the old way of PGD, so everybody here, wherever you go, I wish you luck, okay? My thing, I'm on Resolve board, on every board there is to talk to our new patients. I just love people to be informed, period. And then, and my whole thing is, especially when you come into this and you just expect it's going to be slam dunk, it's going to work, no problem, whatever else. And great news is, it does work for most of the couples that approach this. But there's a lot that can happen along the way that I would just rather people consider how they want to deal with things or really what their options are before they start rather than afterwards, and I wish I knew. So the old technology is take a cell out on day 3 and use FISH, which looks at 5 or 9 chromosomes, and then put the embryo in 2 days later. Because it typically takes about overnight to get the results, and then depending on where your program is, where you're going to ship the material to. Now, Reprogenetics is in New Jersey, and they're one of the leaders with genetic screening, and I've worked with them forever and ever, but they have a facility in my laboratory because I do so much PGD, okay? So if it's a site, go ahead. Yeah. Okay, it's done with the embryo. So a lot of people say, can I test my sperm to see about if they're abnormal? And then some females would say, can I test my eggs? Yes, all those things can be done, but who cares? We don't want to do that. And that's not really that reliable. You need to test the embryos, okay? So aneuploidy means abnormal number of chromosomes. And it can be missing a chromosome or having an extra chromosome, okay? The majority of abnormalities are legal, meaning that embryo is just never going to implant, which means wasted cycles, okay? Or it's going to end up as a miscarriage. Those are the greatest percentages of what abnormal embryos are. The ones that we always think about when we talk about abnormal embryos are Downs and trisomy 18 and 13, which are ones that can go full term, very, very unhealthy. If they find out about one of those in the pregnancy, 100% it's recommended to terminate the pregnancy, okay? So those are the 3. Trisomy 21, which is Downs, trisomy 18, and trisomy 13. There are other abnormalities that can go full term, which some of you may have heard, which is Turner syndrome or Klinefelter's, where it's male, there's an extra chromosome, and often they can't reproduce. So there's other types of chromosomal abnormalities that can go full term, and it's a matter of question: is it desirable? Should we not transfer those? That's a whole separate thing that we're not going to get into here. But the 3 biggies that are very unhealthy in those things is the ones that I mentioned. But so, for example, as I said, let's say a donor, fertilization is the easiest thing to have. Oh, I know. I'm going to hire you to follow me around. This is what I do all the time. Okay, good. So, day 3 versus day 5. The majority of programs still offer day 3. And if they tell you it's the same, you're going to call them on there, you know what? No, it's not. But it's not because you're going to remove. So, on day 3, at best, an embryo has 8 cells. So what would be considered appropriate, good, 5, 6, 7, or 8 cells on day 3 still has potential so much, it's too much of the volume of the embryo is being removed compared to at day 5 and day 6. That embryo has over 100 cells. It's a big, I've got a great picture on there. We should just put it on and let it roll as I'm talking, and then I can show them. A blastocyst has a lot of cells. And so if we biopsy, so what genetic testing is taking some cells from the embryo and getting the karyotype and looking at what the chromosomes are. So is it normal? Is it probably most of your are abnormal? And obviously mine's different than yours. So I'm XX, you're XY, but then all of our other chromosomes we want 2 copies. If there's only 1 copy, it's going to miscarry or it's not going to implant. If it has an extra copy, that's those conditions I told you. So by taking a little cluster of cells out on day 5, it's more robust. It's more robust, so it's more accurate information. Secondly, it doesn't harm the embryo because the embryo easily gives up those few cells. But the most important reason why it's more beneficial, what happens on day 5 or day 6, the embryo has decided which cells are going to make the fetus and which cells are going to contribute to the placenta. We can see the difference. We don't have to go anywhere near the fetus by waiting and doing this on day 5. And so we remove those outermost cells, whereas if you take a cell out on day 3, that cell we can't tell where it's going to end up. So we might be taking one of the most important cells in that embryo. So we did it too. We did it for years and years and years. We did day 3 biopsy because that's all you could do. But it should not be. But day 5 biopsy is much harder to do, but it's much safer on the embryo. And the goal, and you're only testing embryos that have reached the blastocyst stage. An embryo has to reach that stage to become a baby. Have I completely lost everybody?
So do you then?
Cost? Okay.
So just in summation, do you then insert it without freezing it, or?
Okay. So we can do both. Many groups, now when I say many, in terms of doing this technology of PGD, there's a great one in New Jersey, there's us, there's Dr. Surrogacy in Colorado, there's Huntington in California, there's very few programs that do this. Most of them, yes, do have to freeze the embryos to get the result. But we have the laboratory on site, so we do the transfer the next day. Now freezing them though, many of our same-sex couples freeze all of their embryos because they have their donor, they come to Chicago, they get their sperm done, they have their donor. It's the surrogate that's usually what takes the longest time. And so, and often, so these are the different ways, and many groups still do this, which is testing the egg. What you ask, can you test an egg? Yes, but even if it's a normal egg, if the sperm cell is abnormal, resulting embryo is going to be abnormal. So you don't really want to just test the egg. You want to test the embryos. And so this is a day 3, and the majority of PGD programs that are out there still do this because this is much easier to perform, and you don't need a different type of embryologist. Okay, much easier. And it's like, and all their equipment and all their technology that they have, they heavily invested into this. So this is the only way. I'd rather you not do PGD than to do this. It's not worth it because you have a good outcome, a good chance you can have a good outcome without it. Now, if you have your contract, so if you're not going to do PGD, your lawyer is going to help you figure out how you're going to deal with termination. But that's just one piece of the value of PGD. Many of my couples, quite honestly, the other reason why they're using it is they want to. Meaning